So BPH is, in the vernacular, an enlarged prostate. And essentially the prostate is a donut that sits around the urethra that is a potential barrier from urine getting from the bladder down the urethra and to the outside. And so when we're young, that donut is not in the way, but as we get older, it enlarges and one goes from urinating through a tube that's this big down to one that's, say, maybe this big. And with that increased resistance, we see lots of symptoms. Feeling of incomplete emptying. The bladder has to work harder, so it becomes more urgent. It sets people up for a risk of infection and potentially bleeding from the prostate or stones. And in a worst case scenario, it can even proceed to the point where the patient is unable to urinate at all. Getting up at night is often a typical symptom of BPH as well, where people sometimes have to get up 2, 3, 4, I've seen up to 10 times a night in order to empty the bladder. It's largely age-related. So as we get older, I tend to start seeing BPH symptoms in men in their, sometimes as early as their late 40s, and then by the time we get up into the 60s and 70s, we're certainly seeing quite a bit of it in that age group. So the vast majority of patients are able to be treated medically. Again, we really have to base the degree of bother and how bad their symptoms are. Certainly, if somebody can't urinate and requires a catheter, that's a much more severe situation than the person that gets up maybe one time a night. But we sort of have a spectrum of treatments that we would offer. The most simplest thing are medications called alpha blockers. They tend to open up the bladder neck and open up the prostate, let the bladder work a little bit easier, and they work very well and they work very quickly. They don't tend to stop the progression of the BPH, and so symptoms may continue to accumulate over time. There's a second class of drugs, a drug called Proscar and a drug called Avodart, and the way those work are by basically preventing the prostate from seeing the testosterone that it needs. So the prostate takes testosterone, changes it to a form that it can use, and then uses that to grow. So these two drugs prevent that conversion. And so the rest of the body sees testosterone just fine, the prostate can't. So it shrinks by about 20 to 30% over the course of about 6 months or so. Again, decreasing what's in the way and allowing the bladder to work better. Tends to work better for larger prostates than it does for smaller ones. It's pretty intuitive. If you got a guy that's got a prostate the size of my fist, 20% of that is a lot more than 20% of a prostate that's the size of a plum. And so we tend to reserve the use of that for patients who have larger glands. I often don't start with that therapy. I'll often add that as a secondary one to the alpha blocker. There are studies to show that both of those types of medicines in conjunction work better than either one alone. Of course, with concerns for polypharmacy, I tend not to go with 2 to start, but if we need to do that, we do. Beyond that, we do have some medicines that are more targeted for the bladder to help with the overactivity symptoms, the urgency and the frequency to getting up at night. Those medicines tend to be more side effect heavy, so I'm much more select in who gets those. And then, of course, we have the procedural options or the surgical options, and we're going to carve out that inside of the prostate manually to open things up. And there's different ways that can be done. The traditional way is using what we call electrocautery to sort of shave out the inside part of it. There are lasers that can be used to vaporize the inside part of the prostate. And more recently, people have been doing things like using superheated water vapor to do it. There's even a procedure called the Urolift where there's these little sort of nitinol ties that actually manually pull the prostate out of the way. I don't necessarily do all of those procedures myself, but we do offer all of them within our department.